My name's Melanie Traut. I'm a paramedic and anesthesiology doctor from Germany, and I'm going to talk about volume therapy in hemorrhagic shock, a practical guide for pre-hospital treatment by paramedics in Uganda. The definition of shock. Shock means a mismatch in need and supply of oxygen, caused by insufficient or breakdown of circulation. In hemorrhagic shock, we have a loss of blood, which means a loss of red blood cells, which leads to a loss of oxygen transport capacity. A loss of plasma and platelets, which means a loss of clotting ability. A loss of blood also means a loss of temperature and the ability to keep it, and a loss of intravasal volume, which means there's less volume for organ perfusion, and that leads to organ dysfunction. In hemorrhagic shock, we might end up with the deadly triad of shock, which consists of hypothermia, acidosis, and coagulopathy. If you look at the picture, you will find some things I will talk about later. The optimal treatment would be: don't flood, give blood. So don't flood your patient with a lot of crystalloids, but give them blood transfusion. Do damage control resuscitation, which means you expand the volume of plasma, you replace the red blood cells with packed red blood cells, you support the clotting with thrombocytes and fibrinogen, and of course, you do damage control surgery. The problem just is, we are on an ambulance and maybe very far from the hospital. So, what can we actually do as paramedics? We have to stick to our basic therapy. It might seem stupid and simple, but it will do the purpose. So stop the bleeding wherever it is possible. For that, always have your tourniquets ready. Keep the patient warm. Immobilize the patient. So use a pelvic sling or whatever can be used as a pelvic sling, like a belt or something. Put them on a spine board or scoop stretcher and do full body immobilization. And accept a low blood pressure. When you did that, the only thing you can do is scoop and run, because only the surgeon will actually fix the problem. At this point, it might be important to remind people that the maintenance of your ambulance and enough petrol is essential to save lives. We talked about basic therapy, so why it is so important to keep the patient warm, especially in Uganda. It might seem obvious. Normal body temperature is needed for the coagulation factors to work well, so any drop in temperature means a loss of clotting ability. Hypothermia also increases metabolism, so the body will go to anaerobic metabolism, which creates a lot of lactate. The lactate again means acidosis, and acidosis means the function loss of the clotting factors. Immobilization is important because movement might increase or even cause internal bleeding. And also for the patient, it means usually it reduces the pain, because what is painful in broken bones is the crepitation of the fragments. So if we immobilize them, the bones can't crepitate, so it means less pain for the patient. Permissive hypertension means we accept a blood pressure of about 80 millimeters mercury systolic if no brain injury is assumed. If there's brain injury, we need at least 100 millimeters mercury systolic. The reason why we try to keep the blood pressure that low is that higher pressure might destroy tenuous clots and with that increase the bleeding. Get your EDs ready. So this is for all the people listening, working in emergency departments, and for all the paramedics bringing the patients to them. So sit together for the paramedics, go to your hospitals, contact them, ask them for a number you can call if you will bring them a severely bleeding patient. Because from my experience, very often the doctors, clinical officers and midwives on call might not be at the hospital and they need time to come to the hospital. So we have to inform them before we arrive. And also the time of the ambulance arriving can be used to prepare theatre. So in the end, we win time for the patient if we are prepared. There are different types of intravenous fluids. The first group is the crystalloids, with normal saline, ringers lactate, glucose. The second group is the colloids, with haze, gelatin, dextrane, albumin. And the third group is the big group of all the blood products. Whole blood, packed red blood cells, plasma, thrombocytes and fibrinogen. Usually on our ambulance we just have the first group. If you go home and just remember one thing from my lecture, it should be that please, you should never ever use normal saline in a bleeding patient again. The reason is that normal saline consists of water plus an equal concentration of sodium and chlorine of 154 millimole per liter. The normal concentration of chlorine in blood is 89 to 110 millimoles per liter. So already with 1 liter of normal saline, you create a chlorine overload in the body. Chlorine is a negative ion, so we flood the body with negative ions. The body tries to keep normal electric charge, so it retains positive ions, which are usually hydrogen ions. And the problem is hydrogen ions create a lot of acidity. So we end up with hypochloremic acidosis. And that is the opposite of what we want to do when we do resuscitation with our patient. So normal saline will not do the job, so don't use it. If your patient has metabolic alkalosis, that's totally fine. So if they have vomiting or diarrhea and they lose a lot of chlorine, then normal saline is fine, but not for the bleeding patient. Our infusion strategy on the ambulance is we always use body warm fluids. That might also seem obvious in Uganda, but we also go out at nights. So even at nights, try to keep your fluids warm. Use just as much crystalloids as absolutely needed. So remember, don't flood, give blood. We just give so much crystalloids we can keep the blood pressure of around about 80 millimeters mercury. If available, consider using colloids, but be very careful with them because especially dextrane has a very high risk of allergic reactions. So if you give dextrane, always have your adrenaline ready. There are some add-ons. The first and most important one is tranexamic acid. I was so happy when I found out it's available in Uganda. So tranexamic acid is definitely a drug that should be on any ambulance. What does it do? It stabilizes clots, so it inhibits fibrinolysis. If you give it as early as possible. So put in the intravenous line and immediately give the patient the first gram. Then give a second gram over 8 hours. So put the second gram into the infusion bag and let it drop very slowly. If you're interested in reading more about tranexamic acid, I highly recommend to read the paper on the CRASH 2 trial. You will find it on the internet. So I really hope you liked my contribution. I'm very sad I can't be in Uganda today. I would have loved to join you. And I'm very happy for any ideas, any comments, and anything that will help us to make the emergency care, and especially the pre-hospital emergency care in Uganda better. So goodbye, and I hope to see you all again in Uganda.